Well, welcome to everyone for joining us today on March 2nd to Arizona Community Grand Rounds. Thank you so much for joining. I know people are linking in for today's session, Long COVID, Emerging Pediatric Research. Today's session will highlight Dr. Peter Rowe from the Johns Hopkins Children's Center. Dr. Rowe will correct the S after the John in the Johns Hopkins there. I know some of my colleagues who are watching will notice that and want to correct me as alumni of that fine institution. But I'm Mark Carroll, and before I introduce Dr. Rowe, I'd just like to remind everyone, especially for those who are joining us for the first time, that Arizona Community Grand Rounds are hosted once a month on the first Wednesday of each month by the NARBA Institute. Thank you to Mary Jo Gregory, President and CEO of the NARBA Institute, and co-hosted and facilitated by Health Choice Arizona, Blue Cross Blue Shield of Arizona, for whom I serve as the Chief Medical Officer. We began rounds in June of 2020 after some months of planning before the pandemic and started up during the pandemic. And if I'm counting correctly, today is our 20th session. And so we've been very pleased to have some phenomenal speakers on some very important topics. And today will be no exception to that, as I'm sure you will all agree. If you'd like to see previous sessions, they've all been recorded and are hosted at the NARBA Institute website and into the chat. Jennifer Pierce, who is our telemedicine manager extraordinaire who supports these sessions. Thank you, Jennifer. We'll post the link for folks and you can go to that. The recording of this session will be available within the upcoming days. Unfortunately for today, we do not have CME CEUs available, but the topic is so compelling that I'm sure that won't deter any of you from continuing to stay with us. Jennifer, if you can go to the next slide, please. I'll just briefly note that the session next month, so the first Wednesday of April, is April 6th, one of my daughter's birthdays. Just a shout out to Sophia, who's not listening, but it is her birthday. And on that day, we'll actually have a panel talking about evidence and well-being, comprehensive models for best practice approaches to health professional fulfillment. A super important topic, as we know right now, for our entire health workforce, whether in hospital or in community settings or in public health. We have a really great list of presenters for that session. So Jennifer, you can come off of the share if you don't mind, and I'll introduce Dr. Rowe. Right before introducing Dr. Rowe, if you have questions, comments that you'd like to add in the Q&A chat during Dr. Rowe's presentation, please do so. And Mary Jo and I will do our best to synthesize and bring those questions for Dr. Rowe when he's completed his remarks. But before beginning, we're so pleased to have Dr. Peter Rowe join us as a professor of pediatrics and the Sunshine Natural Wellbeing Foundation professor in chronic fatigue and related disorders. And he's also the director of the Chronic Fatigue Syndrome Clinic in the Johns Hopkins Children's Center. Dr. Rowe received his BA from Trinity College, University of Toronto, and attended medical school at McMaster University in Hamilton, Ontario, Canada. He then completed his residency training in pediatrics, fellowship training, and chief residence at the Johns Hopkins Hospital in Baltimore. He was a member of the medical staff of the Children's Hospital of Eastern Ontario from 1987 to 91 before returning to Johns Hopkins, where he's been since then. As I've noted, Dr. Rowe is a professor of pediatrics and Division of Adolescent and Young Adult Medicine. His clinical and research interests for the last 25 years have focused on medical conditions characterized by chronic fatigue. His work has emphasized the importance of a variety of physiological risk factors for chronic fatigue syndrome, including circulatory dysfunction, joint laxity, allergic inflammation, and adverse biomechanical strain. Dr. Rowe's directed the Chronic Fatigue Clinic at the Johns Hopkins Children's Center since 1996, where he is the inaugural recipient of the Sunshine Natural Wellbeing Foundation Chair in Chronic Fatigue and Related Disorders. It's been just a pleasure for me to meet and get to know Dr. Rowe over the years from a variety of avenues. Peter, your work for decades now in a really invaluable space for teens, children and young people has been so important for the work of conditions related to chronic fatigue, and obviously of infinite value right now as we look at the emerging research related to long COVID. Thanks for joining us today, and I'll turn the virtual podium over to you, sir.
Great. Thank you very much, Mark, for the invitation, and to Mary Jo. Very nice to be with you today. And as Mark mentioned, I've sort of been on this swimming upstream path for 25 years, and I think I've gotten more requests for talks in the last 2 years as we've been facing the issue of long COVID. And it turns out that much of the work we've been doing is applicable in a very practical way to the kids who have prolonged symptoms. I don't have any relations to disclose. The objectives are to make sure that you guys know the common features of long COVID. We'll be talking about the Institute of Medicine definition of ME/CFS, as it's now called, and we'll spend some time looking at how we've treated these patients. So the way I want to approach that is just start by making sure we have some sense of what everybody means by long COVID. How common it is in pediatrics, or at least how common we think it might be, what it looks like, and then what we can learn from the past work, really through the lens of ME/CFS, about how to help these patients improve their function. So it wasn't long after the start of the pandemic that people started publishing work about how common fatigue was afterwards. So this was a letter to the editor of JAMA from Italy, showing that fatigue affected about 80% in the acute phase of the illness. And by 2 months of follow-up, at least 50% of adults were reporting chronic fatigue. And this led to a lot of interest in risk factors. One of the early papers pointed out, this was from Ireland, that you can have persistent fatigue even after a very mild infection, so that the risk was independent of the severity of that initial infection. We started seeing things in the newspaper, like this one from David Tuller, a journalist who covers chronic fatigue syndrome, reporting a 12-year-old in New York who had been limiting her activities and had trouble concentrating months after the pandemic infection in early March, and this was in October. The short answer is that we don't have a consensus on the definition of what we mean by long COVID. The CDC uses a 1-month definition to describe several post-COVID conditions. That includes the ones that are the effects of a severe COVID-19 infection, including MIS-C in children. There's also the effect of prolonged hospitalization or ICU admission. We know there's an ICU, post-ICU syndrome, where you get tachycardia, fatigue, weakness, and so on. But really what I think most people are concerned about is the onset of new symptoms or persistent symptoms after relatively mild disease. And that's largely what I'll be focusing on. The other definition that's emerged came in October from the WHO. They call it post-COVID condition, saying that it occurs in people who either have a probable or a confirmed SARS-CoV-2 infection, and it has to begin 3 months from the onset of symptoms and last for 2 months and not be explained by anything else. The most common symptoms they report are fatigue, shortness of breath, and cognitive dysfunction. But there are many others. And in general, if you're going to call it post-COVID conditions or long COVID, it has to have some kind of impact on the person's functioning. It can start as a new onset syndrome after an apparent recovery from the acute infection, or it can persist from the very beginning. And symptoms can fluctuate or relapse over time. And that may be related to a phenomenon that we'll cover called post-exertional malaise. How common it is a tough nut to crack. This was a paper from a group in Rome where they looked at all of the children under 18 who had a positive PCR test during the early part of 2020, up until October, at one institute in Rome. They excluded kids who had severe neurologic disability because they weren't going to be able to answer the follow-up questions. And this group collected 129 patients, only 6 of whom had been hospitalized. 25% were asymptomatic with their acute infection. 3/4 of them had symptoms. There were only a handful that went on to get the severe consequences of MIS-C and myocarditis. The outcomes that they reported, a mean of 163 days after the test, so 5 months or so, was that 42% had recovered completely. But 53% had at least one symptom at the 120-day point. And 43% were impaired by these symptoms in everyday life. So if this study was actually true, if this was reflective of the entire population's experience, we would be in a world of hurt. As David Spodek once wrote, we must view published material critically, if not biblically, for too often the conclusions giveth, but the materials and methods taketh away. And the epidemiology of long COVID is no different. Here are some of the methodologic issues in getting a grasp of the numbers involved. And this is modified from a paper by Zimmerman. One is the definition of long COVID that you use. Should we be saying 1 to 2 months afterwards counts as long COVID, or should we insist on something like a 6-month definition where many of the minor symptoms and the respiratory problems have disappeared? Should we be using clinic-based or population-based samples, clinically assessed or just self-reported symptoms? Is it confirmed infection or suspected infection? What about whether they're hospitalized cases or mild cases? Age makes a difference. Comorbid conditions can as well. I think the duration of follow-up also allows people to see different symptoms. We don't know yet whether the strain of COVID is a factor that we need to consider. And it's very important, as Mary Jo was mentioning before we started, that we look at the general effects of the pandemic on adolescents' health and mental health in particular, and separate that from the effects of the COVID infection itself. Early on, people didn't know to look for some of the symptoms that have become prominent with long COVID, like lightheadedness and orthostatic intolerance. So there were some ascertainment biases early. And I think we're all wondering whether race or ethnicity play roles in the development of long COVID. And that will be a question for future study. One of the more useful places to get population level data is the Office for National Statistics in the United Kingdom. They have a huge sampling population of households with 581,000 individuals, and they ask them periodically who has symptoms persisting for at least 4 weeks after their first COVID infection. And this graph shows you the age distribution of people with ongoing symptoms at 12 weeks in the green and 12 months in the blue. And I think what this slide shows us is that, like ME/CFS, we are unlikely to see it in the very young kids under 10. It starts to emerge in early adolescence, and by late adolescence and early adult life, the numbers are very similar to the adult frequency of long COVID. And if you look in blue, what we're maybe talking about is 1 patient per 200 in the population. And they estimate that in the United Kingdom would result in 48,000 patients with symptoms at 12 months. Keeping in mind that the United Kingdom has about 1/5 of the population of the US, this means that we may see as many as 250,000 new cases of prolonged disability at 12 months. So let's look at what the symptoms might be. And one of the things from the Italian paper that's helpful is the ranking of the symptoms. And this was again at about 4 to 5 months after their positive infection test. So some of them still had insomnia. There was a lot of respiratory symptoms and congestion. We think that those symptoms really start falling off by the 6-month point. It's a bit like mono causing chronic fatigue syndrome. You don't see splenomegaly at 6 months. You're not dealing with sore throat so much at 6 months. You're dealing with the other symptoms of the illness. So fatigue, concentration problems, muscle and joint pain are among the most common of these symptoms. And this was a survey done by parents. They weren't professional questionnaire designers, but this was 510 children, again, helpful for the ranking of symptoms. They were asked 2 to 14 months after the infection, and the prominent symptoms were tiredness and weakness or fatigue. And as I mentioned, this was designed by parents, not by questionnaire professionals. So not sure that you can distinguish those two symptoms, but upwards of 80% were fatigued. Headache was common, belly pain, cognitive problems, muscle and joint pain, and then this phenomenon that we know of in the ME/CFS world of post-exertional malaise, and we'll talk about that more in a bit. Let's look at what we can learn from the older literature. So the Institute of Medicine of the National Academies convened a committee in 2014. I was on that committee. They said 4 meetings, a day and a half each. That's not really much of a burden on you. And I thought, well, okay, I can go down to Washington for those meetings. What they didn't tell us was that in between we'd be reviewing something like 10,000 papers on this topic. So that summer, nobody in the neighborhood was happy with my lawn mowing techniques. One guy put his lawnmower through the hay in the front yard and to remind me that the tasks needed to be continued. But this was a huge effort. We came up with a new definition that's simpler than the older definitions for chronic fatigue syndrome, or ME/CFS as it's now called by the NIH and the CDC. The core symptom was substantial impairment in activities that were well tolerated before the illness, usually accompanied by profound fatigue. So this sort of flips upside down the symptom of fatigue and really focuses more on the fact that the person can no longer do what they used to be able to manage. The second core symptom was post-exertional malaise. The third was unrefreshing sleep. And you had to have either cognitive impairment, which looks very much like suddenly acquiring ADHD with the inattentive form, or orthostatic intolerance. So let's focus on a couple of those. The post-exertional malaise refers to an increase in all of the person's symptoms after exceeding their usual physical activity or even cognitive exertion, such as studying for exams or for board tests. And the symptoms can include many of the things that you might see after a concussion. So worse fatigue, flu-like symptoms, lightheadedness, headaches, light and sound sensitivity, and others. And once provoked, these symptoms can extend well beyond 24 hours. And while this symptom is not unique to ME/CFS, it's much more common in adolescents who have this than it is in people with depression. And you guys know that when we've got depressed patients, we urge them to be more physically active, and it often makes them feel better. Whereas these patients, if they exceed their usual activity, get worse. Just as an example of the science behind this, Alan and Kathleen Light are 2 pain physiologists at the University of Utah, and they did a really interesting study that adds to the biology and the legitimacy of post-exertional malaise. They had people do a 25-minute bicycle exercise, and they measured on the right side of the screen a variety of receptors for sensory pathways involved in pain perception, adrenergic receptors that are involved in circulatory control, and then a variety of cytokines and immune related phenomena. And at the top, you see the changes from baseline to 48 hours in the healthy individuals, really not much change in gene expression. Whereas in the ME/CFS patients, by 24 hours, they had over an 8-fold increase in some of the adrenergic genes. And this correlated beautifully with when they were reporting their symptoms. So this study adds a lot of the biological underpinnings of that symptom. There's something truly going on. We don't know why, but there is nothing that the patients can do to manufacture these gene changes. And these findings have been replicated by other groups. Let's talk a little bit about orthostatic intolerance. This is a term that refers to a group of clinical conditions. And I emphasize that because some people write that the only form of orthostatic intolerance that you can have, chronic orthostatic intolerance in pediatrics, is postural tachycardia syndrome, or POTS. That's not the case. But these are a group of conditions in which symptoms worsen with quiet, upright posture, sitting or standing. And many of them, but not all of them, are improved on lying down. And so, as an example, lightheadedness typically is very quick to respond to recumbent posture. But once provoked, fatigue and brain fog can persist long afterwards. These are the symptoms of orthostatic intolerance, and you can see that there's a lot of overlap both with chronic fatigue syndrome and with long COVID. The symptoms on the left are thought to be due to a reduction in brain blood flow when people remain standing. That makes sense for lightheadedness and syncope, also diminished concentration, fatigue, exercise intolerance. The ones on the right are thought to be in large part due to the very high catecholamine response to a reduction in brain blood flow. We pour out epinephrine and norepinephrine. So it's not really a surprise for any of you who are of my vintage who remember giving epinephrine to asthmatics in the emergency room. It's no surprise that on this list are things like palpitations, tremulousness, and anxiety. This is a diagram of what these conditions look like. The definition of POTS for adolescents is an increase in the heart rate of 40 beats per minute between supine and the peak standing heart rate. You can't have orthostatic hypotension in the first 3 minutes upright. And it's not just a tachycardia, right? It's not an isolated heart rate change. They have to have chronic orthostatic symptoms. On the right is what we've termed neurally mediated hypotension. This is synonymous with vasovagal syncope, but not all of the patients who have this pattern on the tilt table test have syncope in day-to-day life. The drawing or the diagram you're seeing is from a medical student at Hopkins who was sitting in class in her first year and was really getting pre-syncopal on almost a daily basis. We put her on the tilt table, brought it up to 70 degrees. She got lightheaded and pale. And then at the 5-minute point, the bottom fell out. Her blood pressure dropped to below 50. She had a slowing of heart rate that's classic for this, and even a couple of tonic-clonic movements from the immediate drop in cerebral blood flow. We had gotten interested in that physiology when we saw when I was running a diagnostic clinic that children being referred for chronic fatigue and chronic fatigue syndrome had many of the same stimuli provoking their symptoms. So standing in line in a hot environment, really quiet upright posture. So we tilt tested them. All 7 consecutive patients dropped their blood pressure during the tilt test. And 4 of the 7 had improvements in their symptoms when we gave them medicines like Florinef and beta blockers and others to improve their blood pressure response. And we extended this study working with Issam Bohalega, who was a fellow from Saudi Arabia in pediatric cardiology, and Hugh Hopkins, who's shown with him in that picture, who runs our tilt table lab. And in that study, we had 23 adolescents and adults, all of whom had a very bad day of chronic fatigue when they were on the tilt table. So the upright posture could provoke their symptoms, and most of them became hypotensive. What got other people's attention, though, was that when we began treating them openly with the same kind of medications, Florinef, Midodrine, beta blockers, and others, their overall sense of well-being went from a baseline of 35 up to 70 after 4 months. And this had never been seen before. And this really is what we continue to see to this day. And as you can see from the diagram, some people have really enormous improvements, others much more modest. One of the questions, though, has been, well, what's going on? Why are we unable to see the reduction in brain blood flow that these patients have? And that answer was finally addressed in a paper in 2020 by Linda van Kampen and Frans Visser, a husband and wife cardiology team from the Netherlands. I had met them at a meeting. We realized we did a lot of things in common, and we've been Skyping sort of weekly to work on helping them get out data from their practice. And what they do is they take a Doppler ultrasound probe and they put it on each internal carotid for about 20, 30 seconds and each vertebral artery. So they get all 4 vessels bringing blood flow to the brain, and they can measure total cerebral blood flow with this technique. This slide is from a large study of 44 controls and 429 adults with ME/CFS. And it shows the difference between supine and 30 minutes of head-up tilt table testing at 70 degrees. So healthy controls have a 7% reduction in their brain blood flow. If you take all 429 of their ME/CFS adults, they get a 26% reduction. So I think that tells us it's no surprise that these people have trouble finding the right word in conversation or concentrating. When they break down this 26%, the ones who had confirmed hemodynamic changes like POTS or something called delayed orthostatic hypotension, they had closer to 28, 29% reductions in brain blood flow. But importantly, 60% of their adult patients had a normal heart rate and blood pressure to respond. So there was nothing evident there, but they still had a 24% reduction in brain blood flow. I think that 60% of the adult population was at risk for being sent home saying there's nothing wrong with you. We can't say that when we have the brain blood flow numbers, and this may explain a lot of the symptoms of this illness. They had the advantage of looking at some of their long COVID patients. This was a study they published with 10 long COVID patients and then 2 control groups of 20 each with ME/CFS from their database. And one of the things that this slide shows is that there was no significant difference across any symptom that they were asking about. And there are at least 20 of these symptoms that they looked at. So long COVID looked like established ME/CFS. And then on the next slide is one of the diagrams from their Doppler ultrasound. Here on the bottom is a healthy individual who has an 8% drop in cerebral blood flow during the whole 30-minute tilt test. And I think you can see a slight reduction here. On the top, though, is the person with long COVID, and that individual had a whopping 39% reduction in brain blood flow. Again, no wonder that they're really impaired. And these were people who had had 6 months of long COVID. When they mapped out the overall results, as in the previous slide, the healthy controls they selected had a 4% reduction in brain blood flow. The people with ME/CFS and a normal heart rate and blood pressure had a 25% reduction. The ones who had POTS had a 29% reduction. And the long COVID people, all of whom met ME/CFS criteria and all of whom had POTS, were even worse. And you'd think if inactivity and deconditioning was the main risk factor for this, that it would have been the reverse, that the people who had had ME/CFS for 10 years in the yellow and red would have had much worse trouble than the people sick for just 6 months. But this is, I think, a very important study about some of the pathophysiology of the symptoms. Let's shift a bit to look at what we had learned about pediatric ME/CFS, because I think given this overlap that we just saw, these findings are very pertinent to our long COVID discussion. One of the things we thought we knew about ME/CFS is that while a post-infectious onset was common, we thought there was a gradual insidious onset in 25 to 40% who didn't have any apparent infection. As an example, somewhere between 10 and 13% of adolescents meet the criteria for ME/CFS 6 months after infectious mononucleosis. And in the prior studies, the main risk factor for who would go on to get ME/CFS was the severity of the initial mono, how much it laid them up. But I think what we've seen with COVID is that mild or asymptomatic infections can be followed by long COVID. And so whether these patients in the past had a true insidious onset or whether they had one of these asymptomatic infectious illnesses is now up for question. I tell our residents, be very wary of a child having ME/CFS before the age of 10. Usually if they have it, they've got some other comorbid condition combined with it. There's a big peak during the pubertal growth spurt and in adolescence, and another peak at 30 to 39 years, but it doesn't keep getting more common the older you get. People have wondered, is infection something that persists in these patients? And I know that's a question that's come up with the long COVID work, but as in long COVID, nobody's really detecting active infection in the chronic state, although some groups treating ME/CFS patients use antivirals. I think notably the group at Stanford. We have not found that to be an effective strategy. So the question is whether infection triggers some other physiologic dysfunction in a kind of hit and run phenomenon. It's possible, and among the hypothesized mechanisms is that in response to an acute infection, we mount a stress response, but some groups think that that doesn't downregulate and that the person is persistently acting as if their foot is on the accelerator, and this leads to autonomic dysfunction and other changes. It's possible that the acute infection leads to neuroinflammation, activation of glial cells in the nervous system, or mast cell activation as a perpetuating problem. There's been a lot of discussion about the autoantibodies, both in long COVID and ME/CFS, and some groups like Carmen Scheibenbogen's in Germany will use immunoadsorption, which is like a fancier plasmapheresis, to remove all IgG from the individual. They give them IV gamma globulin to restore immunity, but in essence, they've removed potentially pathological autoantibodies. Some of the patients treated that way have an improvement. There's been discussion that the symptoms are due to reactivation of herpes viruses or possibly some kind of subtle mitochondrial dysfunction. These are all active questions in the long COVID world as well. And our hope is that as we have so many more scientific minds trained on long COVID, that something that is discovered in the way of pathophysiology or treatment will also apply to the people who have been impaired pre-pandemic. Just to give you a sense of the impact of this illness, the severity of ME/CFS in adults is comparable to multiple sclerosis and congestive heart failure. Many people are disabled. In pediatrics, it's the most common cause of prolonged school absence. And in the upper right of this slide, I have shown you the PEDS QL quality of life scores in our CFS patients on the left and our healthy controls in that study on the right. And then I think it's a big surprise that if you look at other pediatric chronic illnesses, this is data from the University of Cincinnati in their CF clinic, their eosinophilic gastroenteritis clinic, diabetes, and sickle cell disease, that those patients have better overall quality of life than our CFS patients. And I think the injustice here is that up until recently, I think I had the only dedicated chronic fatigue syndrome clinic in the country. But clearly we need to improve that, not only to take care of these patients, but all of the long COVID patients that we're going to be seeing. We know in ME/CFS that there's a higher female to male ratio, something like 3 to 4 per 1. That would fit if there was an autoimmune etiology of the illness. There are heritable components, so it's more common for both twins to have ME/CFS if they're identical twins than fraternal twins. We described over 20 years ago that this is an illness that's much more common in people who have connective tissue laxity, like Ehlers-Danlos syndrome. And we also looked at people with non-syndromic joint hypermobility. And as you see on this slide, this was a comparison of 58 adolescents who had CFS and 58 controls. And we used a Beighton score to measure their joint hypermobility. A score of 4 or higher is usually considered consistent with that. And when you look at the distribution of these scores, we had what you see in most large studies of children. About 24% of these high school students had joint hypermobility. Those are going to be your dancers, your gymnasts, the kids who are good at swimming, where their hypermobility is an advantage. But if you look at the distribution of the scores in blue in our CFS patients, they were as if drawn from a completely different population. 60% of them had hypermobility. And I would emphasize that that's a feature they'd had since birth. They didn't do anything to bring that on. This is not something that is behaviorally controlled. And so some of the old notions that this was a primarily psychosomatic disease are now being demolished by the data on orthostatic intolerance, circulatory flow, and joint hypermobility. In terms of management, there are very few randomized trials to go by because we haven't had a connected group of clinics and there has been limited funding. But it doesn't mean that you adopt a nihilistic approach. Standard forms of symptomatic therapy that we all know about can be effective for their headaches, their pain, their menstrual dysfunction, the orthostatic intolerance, low mood or anxiety if they have them, or any other condition. I will say that there was a lot of emphasis on cognitive behavioral therapy, largely coming from Europe, as a curative treatment. That was based on the idea that the physical examination was normal in these patients. They were mostly women, so they must be psychosomatic, all of which have been upended. The CBT trials showed that the treatment effect sizes were quite modest, and they weren't sustained after the trial was over. They didn't really study the severely affected patients. The biggest problem has been that the largest of these trials, the PACE trial in Britain, where they compared graded exercise and CBT to standard medical care, suggested that there was a big improvement with CBT. It was only a 2-point improvement on a 33-point scale. But others said, look, you guys changed your outcome measures in the middle of the analytic phase. They got access to the data and reanalyzed the study using the pre-study planned analysis. And they found that there was absolutely no difference. So this was investigators wedded to their hypothesis. And this has become a study that is essentially how not to do a trial. We know that rigid advancement of exercise can provoke post-exertional malaise in this group. I'll just comment on one pediatric study of CBT. This was a study where the treatment group got 10 long sessions of CBT, hour-long sessions, over the course of the trial. The control group was just people on the waiting list who got no intervention whatsoever. So a very unbalanced amount of attention. And David Tuller, whose name you saw on one of the earliest slides, is a journalist who writes about things in this field. He wrote that here's what this study proved. 10 sessions of something lead to more reports of short-term benefit than no sessions of anything. But he asks, 10 sessions of what? Maybe 10 sessions of poker playing, or 10 sessions of watching Seinfeld reruns while holding hands with the therapist and singing The Girl from Ipanema in falsetto would have produced the same results. So a humorous way of identifying the methodologic problems in many of these studies. We did a 3-person case series just to establish that if you have long COVID of a sufficient severity lasting at least 6 months, those patients meet criteria for ME/CFS. So these were 3 young people between 19 and 30 who were all doing well before they got sick. And by 6 months, they met the Institute of Medicine criteria. Let's dig in on and look at one of them in detail. This was a 19-year-old who had Gilbert syndrome, which shouldn't have given him any trouble. He had allergies to pollens and grass that required immunotherapy for 4 years. And he also still has an oral allergy syndrome with exposure to certain foods. He had mild asthma, but it was well enough controlled that he could run for 60 to 70 miles a week as part of his participation on the Hopkins cross-country team. He lived in Florida and he got COVID in June when it was raging in Florida. He had no real hypoxia. He wasn't hospitalized, but it did affect his sense of smell. He started noticing very soon after the onset of the illness that his heart rate was elevated just walking between rooms of the house. At the 2-month point, he played a backyard game of cornhole, and very minimal exertion led to an elevation in his heart rate to 170 for 30 minutes, and then that provoked 3 days of post-exertional malaise. Cardiac studies were fine. When we saw him at the 3-month point, his Biden score was mildly elevated. He had some neurologic irritability indicated by a positive Hoffman sign where you flick the tip of the finger and you get a reflex contraction, flexion of the thumb and the first finger. And the neurosurgeons referred to that as a Babinski of the upper limb. He was a bit tight on physical therapy screening tests, and he had an elevation in his plasma histamine reflecting his allergic inflammation. The worst, though, was his standing test. His resting heart rate was 59 and it rose to 129, went up by 70 beats, more than doubling in just 10 minutes. We tried him on a variety of treatments for POTS that you see at the top. And the ones that actually seemed helpful were clonidine at nighttime. A low dose of methylphenidate helped with his concentration. He'd had a big increase in sensory sensitivity, like just being in the shopping mall was causing him distress. So we gave him a tiny dose of escitalopram, which helped that symptom. And many other groups have reported the same problem with POTS and orthostatic intolerance. The one on the bottom right is from the Mayo Clinic, where they have a big focus on autonomic dysfunction. And like the Dutch colleagues, they found that the most common finding was orthostatic intolerance, often without objective hemodynamic abnormalities. So this young guy was able to manage with some online university courses. Last summer, he tolerated a summer internship, so improving very gradually. By July, a year after the illness started, he still had fatigue, unrefreshing sleep, and post-exertional malaise. And he could walk 15 minutes twice a day, but with that, his heart rate reached 130. So he knew he couldn't advance much more without really risking more tachycardia. In addition to the medicines I showed you, we put him on famotidine and fexofenadine for his high histamine levels. And we use a lot of low-dose naltrexone because it's been found to be helpful in things like fibromyalgia and chronic fatigue syndrome. And with that, he's continued to improve very gradually. This fall, he was able to take in-person classes on the Hopkins campus. He started some physical therapy to address the tightness on the examination. And once he'd done so, he could start adding in stationary biking. And he's been gradually advancing the volume of that so that he can avoid provoking post-exertional malaise. And he's now up to 30 minutes on the bike 4 times a week. And I talked to him recently, and he started doing some run-jog alternation. The other two also had these florid postural tachycardia responses. One girl reaching a heart rate of 166, just standing, leaning against the wall. And this is not from inactivity. These symptoms began as soon as they got COVID. They also had some neurologic irritability that's not something that's been reported widely. One of them had a lot of cutaneous and ligamentous flexibility. The other thing that struck us is that all 3 of them had a lot of allergic inflammatory manifestations. Patient 2 had urticaria with citrus. Patient 3, whose mother is a pediatrician locally, has dermatographism, facial flushing, and the father's on cromolyn for his histamine intolerance. And this investigation was prompted by some work by Larry Afrin, shown at the bottom, who speculates that mast cell activation that is untreated and unrecognized can lead to the cytokine storms that give you a bad initial infection. But mast cell activation may also be rooted in the long COVID forms. The paper by Glynn shows that there is some evidence supporting the use of antihistamines in people with long COVID. Much of that literature is very, very much in its infancy. I mentioned this study from Ireland before. In the conclusion of the paper, the authors wrote, I think incorrectly, that a suite of interventions included graded exercise and cognitive behavioral therapy are needed to manage CFS and may be relevant to post-infectious fatigue. And I would argue that CBT is no longer recommended as the primary therapy of ME/CFS. That was really when people thought this was primarily psychological. It's not. POTS and orthostatic intolerance are among the most treatable conditions and need to be looked for and managed. The CDC guidance talks about how many of the symptoms in patients with long COVID are similar to ME/CFS and fibromyalgia and dysautonomia. So symptom management approaches that we've generated for those disorders can help some patients, including pacing their activity to avoid provoking PEM, as we just saw. For those who want more information on exactly how to manage these symptoms, there's an open access publication listed here. And by the way, I told Mark and Mary Jo that I provide all of these slides for you so that you can look up papers if needed. But this is a primer written by an international group of people who have lots of experience with the illness. We have a paper that's coming out in current pediatrics reports on long COVID-19. And so that has a lot of practical suggestions. I'm anticipating that'll be in press within the month. If you want to dig in more to managing orthostatic intolerance or some of the physical therapy treatments, I've done a number of webinars that you can look up. And then we did something for the Hawaii Pediatrics group that includes a lot of case-based discussions to give you some more practical information on that. So These, lastly, are the patient advocacy groups that have a lot of good talks on the topics we've covered today. And I'll just end by thanking those who've allowed us to continue this work, which is not lucrative work, but it's very rewarding work over the last 25 years. I'm going to stop there, Mark, and we can go on to questions.
Well, Dr. Rowe, thank you so much for a very comprehensive and yet detailed conversation, both on 25 years of work and how that applies to the current situation. I'd invite folks to please enter questions if you have them in the Q&A and chat, and there are a couple that we'll get to in a second. So Peter, what is your, and I know you spoke to this, so forgive me for coming back to a couple of points that you've already referenced, but do you think that many people have a common physiologic underpinning as a response to different infections, and that long COVID is really just a contemporary manifestation for most people of ME/CFS?
Yeah, that seems to be the case, provided that they have this sort of 6-month duration and a significant impairment. I'm sure there are others that have mild respiratory symptoms for a couple of months afterwards. That's probably more along the lines of post-influenza bronchial constriction that we see, for a month or two. But I think the ones who are really quite impaired look like they have ME/CFS, and it may just be that COVID is an easily recognizable trigger to this, and maybe a bit more likely to occur than after EBV infection.
Are you hopeful that now, given the pandemic and given what we're seeing, and that data on potentially 250,000 people with symptoms, it's an estimate, but 250,000 people with symptoms 12 months after an illness, even mild COVID infection, that's a lot of folks. Are you hopeful, and are you seeing an investment coming from NIH and others in research that will enable us to build more quickly on your 25 years of work?
Yeah, I hope people don't ignore the work that all of us have done on this as they start into the long COVID work. And there's been a bit of reluctance to consider them exactly the same, but I think that's sort of foolish. We're hopeful, though, that because there's so many new ideas and different minds coming at the problem of long COVID, that some of it will apply. So, for example, there's some studies in South Africa where people are finding platelet clots, microclots that interfere with circulation, and treating them with different anticoagulants and aspirin. There are other groups that are trying different antivirals or other agents like Crestor and anti-triglyceride drugs to improve the endothelial surface and reduce inflammation. So from all of that, I think we're going to have some very interesting things to try in a more formal setting.
How about any thoughts about the vaccine? There's been literature suggesting the vaccine can decrease the prevalence and incidence of long COVID.
Yeah, I think that's exactly the case. The best way not to get long COVID is don't get COVID in the first place. So I think the emerging data from the vaccinations, especially if healthcare workers in Israel, are showing that people are less likely to get prolonged symptoms if they've been vaccinated. And it's interesting, in looking at our patients in the clinic, I would have thought in the beginning of the pandemic, they would be sitting ducks for even worse trouble after a viral illness, but in part because they may be on antihistamines for their allergic problems, and they're very fastidious about risking infection. They've done quite well, and when they get COVID, it tends to be a mild illness. In terms of vaccines given to people who had COVID, we've seen largely beneficial responses, but not uniformly beneficial responses. We saw one young psychiatry resident who got COVID in November of 2020. 3 months later, she gets the first vaccine, and she has been basically in a dark room ever since with terrible neurologic symptoms. I think what the vaccine might have done is unmasked some underlying cervical spinal instability. So we can't blame it on the vaccine, and we have to keep looking for things that people have that might be causing some of the same findings in hyperreflexia, for example.
I think that's so important. One of the things that you and others have taught me over the years through different conversations and lectures that I've attended is that the unmasking of some underlying conditions, some of them spinal fluid leaking related, and sometimes in someone's body type can be unmasked and identified. And then we have to be careful not to be generalized lumpers, shall we say, into diagnostic categories. Do you agree?
Yeah. I think the vaccines, while not perfectly safe in all, are, as a global phenomenon, have helped us get out of the worst of this crisis.
What are your recommendations about who someone, whether it be a child, adolescent, young adult, should see for potentially having MECFS, which is easier for me to say than the long long term, or long COVID? Are there any guidance for that? There are a couple of questions about that.
Yeah, so a variety of centers are starting up MECFS clinics. Amanda Morrow at our institution has got a clinic with Laura Malone. Amanda's a pediatric rehab specialist. Laura's a pediatric neurologist. They bring in physical therapists and others to help them out with a multidisciplinary clinic. I know there's one at UCSF and probably many others around the country scrambling to be able to help with the burden. I think a lot of it will fall to general pediatricians. Who to send folks to may depend on what their most prominent symptom is. I think if it's a respiratory issue, they're obviously going to need a pulmonologist. The numbers of specialists who deal with POTS and orthostatic intolerance are small around the country. So, there aren't a million people to send folks to. And many times, as we put into that MECFS primer, it's a matter of doing a 10-minute standing test on your own in the office. It can be quite revealing to see how impaired people get just with 10 minutes of standing, when the healthy kids will be completely bored by the process.
I think that's such a great point. And I've seen that type of test be very effective at making a diagnosis. A couple of folks have asked questions about what can they do in the office versus referring all kids or young people or any patient who might have be in this spectrum of symptoms. That primer seems like a nice starting point. Would you agree?
Yeah. I think that's what we intended it for, is the recognition that there's a complete mismatch between the numbers of patients affected and the numbers of specialists. But and many of the medicines used to treat orthostatic intolerance, pediatricians are familiar with. One of the ones that we use a lot is simple methylphenidate, and in the same doses that you'd be comfortable using in a kid with ADHD. Beta blockers can control the heart rate if it's elevated. Florinef is easy to use and expands blood volume. And some of the SSRI and SNRI drugs can help with specific symptoms. So there's a lot that pediatricians know to do, may not be entirely comfortable trying it out on a long COVID patient, but remember that none of us have the answers to this yet. The antihistamines, both famotidine and other standard ones like loratadine, can be helpful if there's a lot of allergic inflammation in the background. So I think as we learn to treat these patients, those things are available to us. Also making sure that if they're a bit tight on their exam, or if you're not comfortable with your own musculoskeletal exam, send them to a physical therapist nearby who might be able to help them improve their tolerance of exercise.
Yeah, thank you. Any overlap or correlation, symptoms, conditions with frontal lobe seizures or restless leg syndrome?
We have not seen much of that in our patients who had the MECFS or long COVID. But they may not be getting referred to me. And so it's possible that the neurologists are seeing a different set of symptoms.
Vaccination, a couple of additional questions about vaccination. Do you know, does the data show full vaccinations needed for PROTECT? Is one dose of a vaccine partial? Do we know enough to be able to speak to that?
I haven't looked at that literature carefully enough, Mark, but I would think that, some vaccinations better than none in controlling the immune response. Some folks have said that there might be immunoglobulin deficiencies. IgG3 was described in one paper, and we've seen that a bit in the ME/CFS population, where maybe the virus doesn't get as contained initially as would be optimal, and that's part of what allows the chronic symptoms to occur.
The unmasking is an interesting topic and area, and of course, the more we learn about our immune systems and just about our not just our genotypes, what we carry in our genes, but the unique aspects of just our physiologies and how they're different. Is there any suggestive evidence just from the ME/CFS work that there are differences based on someone's ethnic background, race, or culture?
We are really interested in that topic. I'll give you an example. When you do epidemiology studies of ME/CFS, population-based recruitment, especially in a couple of them that have been done in Chicago, the rates are that African Americans are one of the most commonly affected groups, and Hispanics even more so compared to Caucasians. And that's been in a couple of big epidemiologic studies, but when you look at anyone's clinic, mine, for example, in our cohort study of 55 kids, we had 95% Caucasian, we had 4% American Indian, which Native American. So, that was interesting, and 1% from Asia, but no Black kids, even though we hope that we have no barriers to entry into the clinic. And in one study in Australia with 800 patients in Melbourne, where the population is 25% Caucasian in Melbourne, they had a 90% prevalence of Caucasians in their clinic. And it wasn't just any white people, it was people from Scottish, Irish, Celtic backgrounds. And they had 11% Scandinavians in Melbourne, when that's 0.2% of the population of Australia. So there may be some biological factor that's related to mitochondrial genetics that affects the risk. But we have to look at that dissonance between what we see in the clinic around the world and what the epidemiology studies are doing, because I think we could be looking at individuals of color in the wrong way, maybe assuming that in East Baltimore, for example, that everybody who's fatigued is depressed because their brother got shot and their father isn't at home, and all of the other things that are associated with poverty. And we have a young African-American former adolescent medicine trainee who's joining me in the summer to start really digging into the data on these questions. And I think COVID gives us an opportunity to look at this because of the number of kids who are African-American and Hispanic who lived in perhaps poorer environments and were more likely to get COVID. And so we can now ask, are they more likely to get long COVID now that we're following them?
Those are such important topics, of course, for us to look at from the perspective of equity and access. And so glad to hear that that's being explored. And I know we'll be discussing that more collective as well as in our respective organizations.
And Mark, I would say that, one of the issues of equity for me is that if we start long COVID clinics, they can't be restricted just to people who suddenly got ME/CFS post-COVID. We have to be able to provide care to the ones who have gotten ill before the COVID pandemic. It would seem to me to be the height of unfairness to exclude them from quality care.
Absolutely. And for people who may realize that some of those symptoms before are now symptoms that they can receive help regarding, that's going to be very important for our messaging. What advice would you offer to someone, maybe even one of our participants today, who's had some just odd symptoms be evident, perhaps after having COVID, maybe atop of some previous allergies, things like tremors or hand tremors? Any suggestions? Is that common? Or is it, get into go see someone and try to unpack some of this?
Well, some of it may be like, we don't understand why we're seeing the neurologic irritability in our patients, where they might have tremors or brisk reflexes or pathological neurologic reflexes, is that because the virus causes some swelling in the peripheral nerves and then that creates the hyperreflexia? The mast cell issue is something that really deserves a lot more attention in people who have fatiguing illnesses with a lot of allergies in the background. So sometimes that is important. It's important to identify what foods might be triggers, what smells or chemicals can be triggers of symptoms. Mast cell activation syndrome is one of the conditions that we see with the most varied group of symptoms. And so anything strange and unusual, you might want to think about that as a diagnosis. And the treatments for that are often over-the-counter supplements or simple things that we all know how to use, like antihistamines, H2 blockers, cromolyn, oral supplements like quercetin. Even aspirin has been found to be useful for some patients with mast cell issues. So maybe seeing somebody who's got some familiarity with that problem is a helpful way to go. And I can't underestimate or underemphasize the help that physical therapists can give patients when they have these chronic longer-term illnesses. They're not there to push you to exercise. They're there to clear out any areas of muscle spasm, myofascial tightness, and often can improve quality of life when our medications don't do much of anything to help.
Dr. Rowe, you've been very generous with your time, and I know you offered to go a couple of minutes after the 1 o'clock hour in Arizona, 3 o'clock your time. So for folks still here, we will stay for a few more minutes. Mary Jo, I have one last question I'm going to pull from the chat before turning it over to you for questions and perspective. And Peter, this is from a mutual friend of ours, Jane Oskey. Sorry, I haven't called out other names, but Jane, thanks for joining and thanks for your question. Jane asked, do you think the reported association between long COVID and evidence of past EBV represents unmasking of ME/CFS?
Yeah, Jane, very good too. I can't see you, but always nice to be in your presence. That's one of the main theories that people have speculated is going on, that you can reactivate EBV. There's some evidence from Germany that you can reactivate human herpes virus 6, and it causes all kinds of odd changes in the morphology of mitochondria, at least in an animal model. And so the bench scientists and virologists are looking at this carefully. We don't know what we would do about it, but it may explain some of the situations that provoke symptoms.
Thank you. Mary Jo, I've dominated the questions.
Thank you. Well, it's been a wonderful and rich learning experience, Peter. Thank you so much for your generosity of spirit and time and professionalism. One question I saw that was early on when you were talking about the joint hypermobility, were you, just for clarification, was that you see a higher amount of folks in that age group with that, or that it is a contributing factor or a positive factor? I think there was some confusion there.
Oh, okay. So first of all, it's important not to suggest that joint hypermobility by itself is a disease or a problem, right? Most kids with hypermobility are not going to go on to get ME/CFS, but there's a threefold increased risk of being hypermobile if you have a diagnosis of ME/CFS. So we think it's a risk factor for getting sick. And the way we've speculated that it would be involved is not so much because of the hypermobility of the joints, but because that same stretchy connective tissue is also in the wall of the blood vessels. So you stand up, you've got these stretchy vessels that will dilate in response to increased hydrostatic pressure. That allows the patient to pool way more blood in the lower half of the body, and then there's way less coming to the heart and brain, and that sort of starts the cascade of symptoms. Some of them also, my Dutch colleagues in their adult patients find that's leading to way more reductions in brain blood flow in their hypermobile ME/CFS patients than in the ones who don't have hypermobility, by a factor of about 10%. So it may be that they are further impaired by much worse brain blood flow reductions.
Oh, fascinating. Thank you. Just wonderful. I think we're going to have a lot of follow-up questions, and this has just opened a whole new area of specialty. I'm certain that the pediatricians that were joining us today are well aware of it, but for those that aren't treating adolescents and aware of this, this is just a great gift. Thank you so much.
Well, thank you for the invitation. I think, one of the things I would end with is just to say, these folks are sick. Validate their experience, listen to them, even if you don't understand it very well. It's taken us a long time to have this framework for approaching the problem. But I think the best advice is to listen and validate their experiences.
Well, thank you so much for such an important concluding remark. There have been many notes entered in the chat and the Q&A. Thank you not just for your time today, Dr. Rowe, but for your decades of work and experience and commitment to an effort that was hard to get people to talk about in the 80s and 90s, as we all know. And it's proving not just valuable and invaluable for the individuals and their families impacted by this over the years, but for our burgeoning, hopefully burgeoning knowledge moving forward to help perhaps a much larger segment of the population post-COVID. So we're so fortunate to have had you with us today, but even more fortunate as we enter 2022 in a challenged time coming out of the past 2 years, to have a leader such as you really on the planet, Dr. Rowe. So we'll close with just a special note of appreciation and thank you for that work you've been doing.
Thank you.
Thank you.
Very, very nice to be with you guys today.
Best wishes,
so
everyone.
much.
And we'll see you on next month's session, April 6th of Arizona Community Grand Rounds. Signing off for today. Thanks.
Thank you.
Great.